Hello, everyone. I think we'll get started in the interest of everyone's time. We will have more people joining us along the way, so welcome. Andrea, I'll let you do the interpretation.
Thank you. Good afternoon, everybody. My name is Andrea. We're going to be practicing language justice today. We're going to have simultaneous interpretation in English and in Spanish so that everybody can hear and speak in the language of their heart or how they feel more comfortable. Once we turn on the interpretation, you're going to see a globe that is going to come up at the bottom of your screen where you're going to be able to select your language. If you don't see the globe, go to the three little dots or where it says more, and you'll find the interpretation function there. Please remember to speak at a conversational pace. Spanish is 20 to 25% longer than English, so it will take me that much longer to say everything into the other language. Remain muted when you're not speaking and speak very close to your microphone when it's your turn to speak. If at some point you're speaking too quickly, I'm going to turn on my camera. I'm going to look a little freaked out and I'm going to be doing this. And it means please stretch your words so that I can keep up with what you're saying. Hola a todos, mi nombre es Andrea, estoy aquí porque vamos a practicar la justicia del lenguaje el día de hoy y tendremos interpretación simultánea en inglés y en español para que podamos hablar y comunicarnos en el idioma de nuestro corazón. Una vez que aprendamos la interpretación, ustedes van a ver un globo en la parte inferior de su pantalla donde van a poder seleccionar su idioma. Si no ven el globo, van a ver tres punticos donde dice más y ahí pueden encontrar la función de interpretación. Recuerden mantenerse en silencio cuando no estén hablando y hablar muy cerca de su micrófono cuando sea su turno de hablar. And host, we can start interpretation now.
Alrighty, thank you again and welcome to everyone. We're very excited about this event. This is the first time we have done this as the Colorectal Cancer Task Force. Our education committee, I would like to thank everyone who was a part of that, which is Allie and Ella and Shauna and Tatiana and Ian and Brandon. They did a great job really putting this together. So our agenda today is we have a couple poll questions to kind of figure out where everyone is coming from and what barriers. We have two great presentations. And we'll do the questions and answers at the end, and then we'll talk about some of our resources. So yeah, we do have continuing medical education credits. The AAFP has reviewed the increasing colorectal screening in rural and Latino communities in Colorado and deemed it acceptable for up to one live AAFP prescribed credit. Terms of the approval is from July 17th to July 17th of 25. Physicians should claim only the credits that they commensurate with the extent of their participation in the activity. And it's the CMEs are basically available for whoever is live here at the presentation. So we have three poll questions that we would like you all to answer. So while we're waiting for the poll questions, I am going to introduce our two dynamic speakers. We are very blessed to have them here. The first is Dr. Jan Lowery. She is a cancer epidemiologist and an assistant director in the Office of Community Outreach and Engagement at CU Cancer Center. She is also a professor at the Colorado School of Public Health. She has extensive experience in cancer prevention and control research and public health practice to enhance screening in high-risk and diverse populations across Colorado. And she has expertise in implementing science in cancer genomics. Outside of work, Jan enjoys everything outdoors, spending time with family, and pickleball seems to be a big one. Our other speaker is Tracie Lewis, and she is the Operations Director for the Colorectal Cancer Prevention Network at the University of Southern Carolina, where she oversees the statewide patient navigation program and related grant initiatives to expand access to colorectal cancer screening. She brings 2 decades of experience building partnerships across hospitals, insurers, and community organizations to improve cancer awareness and access to care. So we are very lucky to have these 2 wonderful speakers. Ella, do we have any results with the poll? We do. So for the first question, do you currently live or work in a rural setting or an urban? We have 35% of the people are in a rural setting. What is your target population? 17% is Hispanic and 83% is all population. Barriers to care, lack of resources was 70%, language was 9%, and transportation was 22%. So thank you for participating. And Jan, you get to start us off.
Thank you, Peggy, for the introduction, and thank you all for the invitation to be here today. Ella, I think I can now take control. Let me, hopefully this works. So good afternoon, everybody. As I said, it's a pleasure to be here today. I'm going to be sharing some information with all of you about our Fit for Life program, which is a community-based colorectal cancer screening program. And I'm trying to move my slides here, so hang on. Okay, there we go. And while I'm the one presenting today, really all the credit and hard work is done by our community outreach team, and I've shown them here. So Tatiana Guerrena is one of our principal outreach and engagement coordinators. Daniel Pacheco is our program manager, and Samantha Garcia is one of our patient navigators working on this project. All of these wonderful individuals are also bilingual, which is really important for this program. So the Office of Community Outreach and Engagement, just for those, maybe it's worth sort of providing some backdrop, because this is a relatively new office at the University of Colorado Cancer Center. We are one of 72 NCI designated cancer centers across the country. And it's NCI designated for a number of reasons, but in part, they do give us funding, core funding to do some of the work that we do. And about 4 years ago, where many of us working at the Cancer Center were doing outreach work, it was never technically mandated. So now the NCI has really mandated that cancer centers go out and do outreach work within their community. 3 really main things that we do. One is to understand the cancer risks and burden within our catchment area. And for the University of Colorado Cancer Center, that's the entire state of Colorado. Secondly, address the disparities, risks, and burden in our state doing community engaged and informed research. And then the third aim for our office is to do outreach, to go out into community, to bring education and evidence-based intervention. So this is sort of the premise of the why we are doing this work from the Cancer Center. And I put the mission here of our office to reduce Colorado's cancer burden, risk, disparities through our scientific, clinical, and community outreach and engagement endeavors. So this is our internal COE team. We also have other key members, namely Dr. Chris Liu. He's a medical oncologist at the Cancer Center. He provides medical oversight for the program. He is the ordering physician for the Fit Kit program that we'll be talking about, and oversees all the clinical protocols and clinical decisions. We also have critical partnerships for this program, notably the Colon Cancer Coalition. I've listed their website there. They have graciously provided funding for colonoscopies for individuals in need through screened through our program. We also partner with the Colon Cancer Alliance that provides financial assistance for colonoscopies for African Americans screened through our program. And we started our program at the outset with a group called 365 Health. I imagine many of you, at least from Colorado, are familiar with this program. Unfortunately, it disbanded last year, but in 2023, we started this program partnering with them because they had this wonderful infrastructure of doing healthcare or health fairs around the state, and were willing to partner to help us distribute our FIT kits. I did just want to give them a shout out here. So the backdrop of colorectal cancer screening in Colorado, this is what it looks like. These data are from 2022 from our Colorado Behavioral Risk Factor Surveillance System data. These are rates of screening up to date. So it could be through stool-based testing, through endoscopy, or through colonoscopy per guidelines. Statewide, the screening rates are at about 65.5%. But as I've shown in red, the screening rates are lower in some groups and populations across our state, namely among Hispanics, American Indian, Alaska Natives, and Asian populations. They're also lower among people living in rural or frontier areas, those living below the federal poverty level, and you can see dramatically lower among the uninsured within our state. We also see disparities in screening geographically across our state. This is a map that I put together using our new data, our interactive data tool called ECHO, Exploring Cancer in Colorado. I put the website here for those of you that want to access it. It's public facing using publicly available data. And what this graph shows, again, is the up-to-date colorectal cancer screening rates by county across Colorado for the 64 counties. And I've just circled the lighter colored areas that denote areas where there's lower screening rates compared to the state average. So an overview of our Fit for Life program. The goal of our program is to increase screening rates in populations and areas across Colorado with low screening rates or high colorectal cancer incidence. We initially have focused our program on the or underinsured populations, those without a medical home. And we've designed the program, or intended to design it, for broad reach to reduce barriers such as language barriers, transportation barriers, and to maximize participation so that everyone across the state can have access. The screening modality we're using for our program is the FIT test, fecal immunochemical test. I know all of you are probably familiar with this. It detects hidden blood in the stool, a possible sign of colorectal cancer. It does not mean you have colorectal cancer if you have a positive test, though one would be recommended to do a follow-up colonoscopy to rule that out. The nice thing about the FIT is that it's not invasive. There's no special prep that's required, and importantly, it can be done at your home and delivered through the mail. So the model of our program is what we're calling a community outreach screening program. So it's not tied to a specific clinic or healthcare system. You'll hear later in this webinar from Tracie, whose program is a nice contrast to ours because she, in fact, their program is tied to a clinic or healthcare system. The way we distribute FITs is in person at events and fairs. And now by mail, we have now initiated an online request form that is available in both English and in Spanish. And our program intends to provide what we call end-to-end support, starting with just education about colorectal cancer, the risks. It involves screening, of course, the FIT program, navigation to colonoscopy, and to treatment as needed. And our program is free for all eligible people living in Colorado. This is just a snapshot on the left of our website, our COE website within the Cancer Center. You can see if you click Order Your Kit Now, it'll pop up on the right. This is a request form. Again, you can see it's available in both English and in Spanish. We ask some simple questions to determine eligibility, and if eligible, we collect information so that we can mail individuals a kit. The target audience for our program are persons without a medical home, the and underinsured, Hispanic populations, and those living in rural areas. Also targeting areas, as I mentioned earlier, that have low screening rates and high colorectal cancer incidence. Eligibility for our program mirrors that set forth by the American Cancer Society, ages 45 to 75, have not had a FIT stool-based test in the past year, Cologuard test in the last 3, or colonoscopy in the last 10 years. Again, we are focused on those that do not have insurance or who are underinsured. Participants must live in Colorado. And while we will not deny individuals, we do collect information on family history and symptoms, and they are certainly eligible to get a FIT kit. However, we also have a protocol where we recommend that they seek colonoscopy in lieu of starting with a FIT kit. Several different outreach strategies that we employ, again, attendance at health fairs or other community events across the state. We started a new outreach through local newspapers, primarily in rural areas, and using social media. So this is a little bit busy, but I wanted to show on the left, again, these are 64 counties across Colorado, to show you sort of the breadth of our outreach across the state. The circles in red denote these are local newspapers that Daniel Pacheco has researched and identified. These are in rural areas where a lot of people read the newspapers to get their news and information. Many of these have run stories about our FIT program, and we have received several request forms for people living in those areas for our FIT kits. And then the purple squares denote the events that our team has attended across the state. And it's not just in some of the boxes, there's more than one, right, in a certain area. So you can see sort of the breadth of our outreach across the state. And on the right shows the FIT, where the FIT kits have been distributed to date, 861 so far, covering 42 counties across Colorado. This is a flow chart of how our program, from the participants' perspective, a FIT kit is received either in person because they've attended an event that we were there and handed it out, or we've put it in the mail to them. Soon after an individual is mailed a kit or is handed a kit, we start follow-up, and we do, I think, 3 follow-up calls or text, depending on the preference of the individual that received the FIT kit. We do this in both English and Spanish, depending on the preferred language of the individual. And again, this outreach is to, did you receive the kit? Do you have any questions about how to use it? Do you have any concerns? Once the individual completes the kit, it's mailed directly to LabCorp, who we're working with on this program. LabCorp will post the results on their lab portal. Individuals that submit their samples can have access to the portal as well, but we have made it a protocol that we will call back everybody with their result because we have access to the portal. And these are calls made by our patient navigator. If the FIT is a negative FIT test, the recommendation that's given is that the individual screen again in 1 year. If the FIT test happens to be positive, we will notify the individual that it's recommended to have a follow-up colonoscopy, and we will navigate them to have a colonoscopy if they so choose. So outcomes to date for our program, again, we've handed out or mailed 861 FIT kits to individuals across the state, 33% of whom are Hispanic, 17% who have noted they prefer to communicate in Spanish, and 35% living in rural areas. 218 or 25% of FIT kits have been returned to the lab, which honestly is rather remarkable given our strategy that's not sort of based within a medical home. 28 of the 218 have come back positive for a positivity rate of about 13%, which is a little bit higher than the average of maybe between 5 and 10%. And of the 28 positives, we've successfully navigated 14 or 50% of those to colonoscopy. The remaining 50% we did not navigate could have been because we lost contact with them, said they were lost to follow-up. They chose not to accept the navigational help, or they may obtained insurance to do it themselves. Of the 14 colonoscopies, screens or exams where we found polyps and 2 with adenomas. So program funding, something we're always interested in public health, that how do we do this program and importantly, how do we keep it going? We are fortunate that we have what I mentioned earlier, core money through the National Cancer Institute to pay for the program, which includes the fit kits, the processing by the lab, of course, our COE staff, which is critical to the success of this program, and all the media and promotional work that we do. We are very fortunate to, again, have the Colon Cancer Coalition as a partner in this that will provide financial assistance for colonoscopies for individuals with a positive fit kit that need financial assistance. We do not receive any state funding for this program. I think that you might hear differently from Tracie as she talks later on, but our funding is, again, just through those two sources. Program successes, I've listed just a few here. I mentioned earlier a return rate of 25%. I think it's quite remarkable. Again, we were meeting people at health fairs, or we're sending them something in the mail. So 25% is actually pretty high given the population that we're targeting. And we believe it's aided by the phone and text follow-up that we conduct, that our staff conducts. I mentioned the high positive fit rate of 13%. Perhaps an indication that we are reaching some high-risk groups, notably those that have never been screened. Being able to provide financial assistance for colonoscopies, for partnerships is critical, and I don't believe we'd really be embarking on this program had we not been able to offer that type of financial assistance for individuals that need it. And then, of course, I can't say enough about the value of having almost all of our team is bilingual. We have materials both in English and Spanish, and our patient navigators are both bilingual as well. There have been some program challenges, again, because of our target population and our methods of doing outreach, meeting people at health fairs, potentially a more transient population that seek healthcare at these venues, and therefore it's a little bit harder to reach for follow-up. They're not sort of based within a medical home, which might make it a little bit easier. We also don't have access to their medical record. So it's important for all the programs we do in public health to be able to evaluate our findings, make sure we can validate colonoscopy was done and any outcomes that come from colonoscopy. At this point, it's self-report and only for those individuals that we're able to reach and that are willing to share the information with us. And then I put it as a challenge. I think it's just maybe a question of how to address people, underage that maybe present with symptoms or family history. We try to align all of our programs when we're in the community that follow guidelines. This is with, the guidance of our medical director. But I presume others have had sort of have these questions as well of how to address these younger populations. And I'm hoping with the Q&A, Daniel, I know, is on the phone and maybe could answer some more questions about this and some of our strategies for that. In terms of future directions, our team has now started to recontact folks. It's been a year since they've had a fit, just to mail them a new kit because we know they should be screened every year. We're hoping to expand the reach of our program with social media and print media, expanding to more newspapers in rural areas. Something that's kind of exciting is partnering with communities. I know there's a lot of you on the line from different parts of Colorado, maybe wanting to do something like this. And the way our program is set up, I think there's really room for partnership here, where it would be local promotion of the program, and then the fit kits get mailed out from the cancer center. So I think there's a lot of room for growth there. We've talked about adding Cologuard. Right now, we're just using the fits. And then we've also talked internally about ways to get a medical release so that we can follow up and get more validated outcomes for our program. So this is a QR code that people can just scan and get access to our online request form. I think we've had this in place now for probably 6 months. And so far it's proven to be very successful. So I will stop there. I know we're going to do a Q&A at the end, but I'm hoping that Daniel and Tatiana, perhaps on the line, can help answer some of those questions. So thank you. That's our Fit for Life program.
Thank you so much, Jan. That was a wonderful presentation. And We're going to have Tracie speak next, and then when she's done, we'll have the question and answer session.
Good afternoon, everybody. Thank you so much for your time today. I'm Tracie Lewis. I'm from South Carolina. I oversee the Colorectal Cancer Prevention Network program. We currently cover 42 out of 46 counties in South Carolina. So we do serve a mixture of rural and urban patients in our program. And I'm going to highlight some of the things that we did within our program, specifically our screening program, and then some of the work that we've done with our CDC funding that we received for the past 5 years within clinics. Let me see if I can there we go. Okay. I'm going to talk to you about 2 initiatives. One is our screening program that targets uninsured, underinsured, low-income residents of South Carolina, and then specific work that we did within 4 federally qualified healthcare systems in the last 5 years to increase CRC screening rates. Okay, just to kind of highlight some of the population change that we've seen in South Carolina over the past 2 decades, specifically the growth of Hispanic and Spanish-speaking individuals in our state. The number of people who speak languages other than English in their household jumped more than 21% from 2010 to 2019. We have more than 63% of speakers of non-English languages speak Spanish. And South Carolina is one of the top 5 states for Hispanic population out of the country. And for Miller counties, the Hispanic population grew 300+% from 2000 to 2020. So we've had a huge change in our our population demographics, and many of our healthcare and community organizations have been trying to address this change in population. Let me see. I think, Allie, I think somebody's going to have to change them for me. But just to kind of highlight some of our specific counties that have had the higher increase in Spanish and Hispanic population growth. In 2000, Greenville County had 10,000 Hispanic residents. And then in 2020, they had over 60,000, which was over a 300% increase. In Greenville County, just to kind of reference for you that are not familiar with South Carolina, Greenville is in the upper western part of the state. It kind of borders North Carolina and Georgia. And then we had 5 other counties that now have over 5,000 population, which is Richland, which is Columbia, South Carolina, which is our capital, Beaufort, Charleston, which is in Horry County, or our low country counties. A lot of migrant workers are in those counties. And then Spartanburg County is attached to Greenville, so upstate. So we really are seeing a lot of tremendous growth in the upstate, in the low country, but just a little bit in the Midlands area of our state. Next slide. So, so prior to the last several years, we did have one bilingual navigator that could manage the Spanish-speaking referrals that we were receiving through our program. But over the last 2 years, we have not been able to meet the demand of our Spanish-speaking referrals with just one bilingual navigator. And our program is state funded. We are a recurring line item on the state budget. And so we are limited in the amount of staff that we can have based upon our funding. So when we started noticing the trend of our increase in Spanish referrals, we started partnering with ACS CAN to advocate for more funding for our program at the state level. We were unsuccessful the first year that we attempted to increase our funding, which made us kind of start looking for other funding sources. And so Exact Sciences has they currently have focus grants that they offer to non-for-profit organizations that are working on colorectal cancer and increasing screening rates. So we applied for a focus grant through Exact Science. We were awarded, which allowed us to hire a second bilingual navigator to focus in the upstate, because that is one of the areas that we're seeing the greatest increase in Spanish-speaking referrals. So then we attempted this again to increase our funding from the state. And we last July, we were successful and did increase our state funding. So then we were able to hire a third bilingual navigator. So we are now up to 3 bilingual navigators. 2 of them are currently covered through state funding, and our one is currently covered by Exact Science Focus Grant. So kind of just let you know, kind of tell you how our bilingual navigators are funded. But as you can see on the slide, you can see in the left-hand graph the number of referrals that we received through our program starting from fiscal year 2022, which was 103. And our last fiscal year, which ended in June 30th, we had received 1,224 referrals. So you can see the increase in referrals that we've had starting from 2022 till just 2 months ago. So as a great increase. And then you can also see the impact of having increase in bilingual navigators, that we were able to increase the percentage of Hispanics screened to a 33.6%. So we're very excited to see that we are increasing the number of Spanish patients screened within our program. Next slide, please. Not only were we predominantly English-speaking patients from the beginning of our program, but we would occasionally have a Spanish-speaking patient that we would work through other resources to kind of translate our process with them. But since we started having this increase in Spanish-speaking referrals, we were looking at all of our materials. How could we really truly have materials in English and Spanish? And how could we fund converting our English materials into Spanish? So Prevent Cancer Foundation, they offer small $2,500 community grants. And so we were able to apply for one of those grants to convert our videos from English into Spanish. So this is our Clear Liquid Diet education video that we provide to patients when we're navigating them for colonoscopies. We do have it in English and in Spanish. And so here's a QR code, so y'all can have access to these videos if you'd like to use them within your clinic. Next slide, please. Not only did we convert our videos, we also converted all of our printed materials that we use within the community and with clinics when they are referring patients to our program. We have four quick questions to really determine if a patient is of average risk and increased risk. So we like to use those in clinics and at health fairs or community events where patients can read the questions and answer them. And then it encourages them to talk to their provider about their responses so that the provider can really truly have an informed decision conversation with the patient about which screening modality is the most appropriate for them. It also hopefully will help identify individuals who need to be screened before 45 due to family history. In the middle, you see is our navigator referral document. So when clinics refer patients to us, they can hand this sheet out to the patient saying that you have been referred to the Colorectal Cancer Prevention Network for your colorectal cancer screening. Please expect a call, and my navigators are assigned to specific federally qualified healthcare centers and free medical clinics that we partner with. So those clinics can actually point to the navigator on the sheet, and the patient can actually take a picture of the QR code, and it automatically puts my navigator's name and phone number into that patient's cell phone, so that increases the likelihood of the patient picking up our phone calls when we call to recruit them for our program. And then lastly, on the right-hand side is our campaign for March in regards to drawing attention to signs and symptoms and talking to physicians, talking to your doctor about your symptoms. We have it in English and Spanish. There's a QR code that takes them to our website for additional information around colorectal cancer. And I've included a QR code that will take you to all of our documents if you'd like to use those here in this slide. Next slide. And the one other thing that we did within our own program is that our new hire bilingual navigator is truly, her first language is Spanish. English is her second language. So she was having to read our database questions in English, translate them in Spanish, and then talk to the patient in Spanish. So we realized that in order to make things efficient for our bilingual navigators, to have our own personal database system where we track all of our patient correspondence. We ask specific questions in regards to medical history, how we determine if a patient is eligible for our program or not. We have completely converted our database system to Spanish so that our bilingual navigators can use it in English or in Spanish, whichever way they are more comfortable in using our software when they're talking to patients. And next. In the past 5 years, we have been the recipient of a CDC cooperative agreement to implement EBIs in federally qualified health centers to increase CRC screening rates. I'm going to kind of talk to you about the QI process that we utilized within the clinic to kind of determine where their need was or what type of patients they were missing. And since this call is specifically on reaching Hispanic patient populations, I'm going to take it from that angle and show you some of the data sources that we used in order to drive some of the conversation around patient populations. Next slide. So within our state of South Carolina, our Primary Healthcare Association, our statewide Primary Healthcare Association, received funding to provide a health information tool that sits on top of federally qualified healthcare centers EMR. So it helps extract data. Specifically around EDS measures. And so that way they can look at their data and kind of figure out where they need to make changes in regards to how they're reaching certain patient populations within their clinic. So this is a report that we utilized through Azara with our clinics to look at the type of patients by race and ethnicity and preferred language in regards to what percentage of that patient population were being screened. So I kind of highlighted in red the ones that were specific to Hispanic patients or Spanish-speaking patients and the percentage that were screened based upon that clinic location. So you can see here that roughly around 20% of their patient population that spoke Spanish was screening compliant. So this information allowed them to kind of say, okay, we know we're not meeting our the need of our Spanish-speaking patient population. How can we change that? So with that mindset, we had this 20%. And if we did the next slide, we started off with developing an aim statement. And what is our specific numerical goal? So here it would be, we would like to increase the Hispanic patient population compliance from 24% to 30%. And then a time period. So this kind of really truly helped them set specific statements in regards to how they want to increase screening within their patient population. Next slide. And once they set a goal, we actually, what we call is a workflow sticky note exercise, where we kind of highlighted what everybody in the clinic's current role is with colorectal cancer screening. Just so that everybody can see who's touching the patient when and how. So every staff had a different color. So the provider was one color, lab tech was a different color. And what we did is we took this information and we made it into a swim lane so that they could really truly have a visual aid on how they were truly the workflow of how they work that patient. So if there was a call prior to the patient coming in about CRC screening, and then after we did this, next slide, we really took that root causes. Why, we kind of had the discussion around why were Spanish-speaking patients or Hispanic patients not being screened, and kind of took them through this root cause analysis to determine where in their system was something not working as well as they thought it was working. And so once we identified areas that they wanted to focus on through this root cause fishbone exercise, we were able to develop plan do PDSA cycles. So the fishbone activity really truly allowed them to really examine their process and where there were some breakdowns in regards to the system, and really truly hone into what they wanted to change in order to be successful in reaching the Hispanic patient population. And if that was, utilizing their bilingual staff in a different capacity than where they're currently using them. Some of them used their bilingual navigator or not navigator. They had what they call patient care coordinators. They use them to kind of make the reminder call to the Hispanic patient about their upcoming appointment, and kind of, laid the groundwork that, hey, when you come in, you're going to talk to your doctor about colorectal cancer. That was one thing that they have implemented. Some of them did more text messaging in regards to directly to the patient in their native language, so that they could communicate in regards to that it's time for colorectal cancer awareness screening. And so they were allowed to run a couple of cycles to see what was working, if they needed to make some changes into their new system. Next slide. And it's just another cycle of that. Next slide. I think that's it. So at the end of the day, they were able to start the process of identifying certain specific patient populations that they wanted to target within their clinic. And then they were able to test the new process out to see how well it worked, and if they were successful. And then we monitored their screening rates throughout the following year to see if there needed to be any more tweaks to their process. And that is it. And I think we can go to the next slide, which is questions for Jan and I both.
So this is Shauna Richardson. Just to let you know, Tracy, we have a few questions for you. There was a question, was the population insured?
No, they all, in regards for the Colorectal Cancer Prevention Network, our patients are uninsured or underinsured. For the CDC project, it was all of their patient population in regards to Hispanic. So it could be uninsured or insured.
The next question was referrals versus actual screenings.
In our program for the Colorectal Cancer Prevention Network, that's a great question. So when we partner with federally qualified healthcare centers, free medical centers, and hospital-based primary care clinics, we let them know that probably we probably screen 30% of all referrals that are sent to the CCPN. And that the reason being is that the GIs, the pathologists, and the anesthesiologists all waive their professional fees. So they have set parameters in regards to patient population that we can send to them. So they have to be asymptomatic because we're a screening program. They have to be in stable medical condition, which means that if they had a heart attack 6 months ago, we cannot see them in our program until they've been 12 months post that heart attack, or if they've had a stroke, it needs to be post 12 months. So we have, illicit drug use is another thing that our program doesn't restrict, but they have to be, some of our partnering centers require them to be off of illicit drugs for 6 months. Some of them do not. So depending on where the patient lives, they may not have a colonoscopy endoscopy center close by. If they're willing to travel, we have transportation funding. So if they're willing to travel that to a place that does take illicit drugs, we can get them screened through that. So we do have criteria and eligibility standards that is the reason why we're not at 100% in regards to referrals.
Next question is, and how about if the patient tests positive and needs a colonoscopy? Are there funds if the patient is uninsured?
Yes. So in our program for the Colorectal Cancer Prevention Network, we screen with FIT or Cologuard. If that test comes back positive, then we move forward with covering the colonoscopy. I didn't really give y'all stats in regards to our screening program, but just kind of give you some stats. For FIT, we've been doing FIT within our program since 2018. We run a 75 to 78% FIT return rate in our program. And we, like Jan showed in her data, we do run a between 11 and a 13% FIT positivity rate in our program. And out of those patients that are positive, we run about, we're hoping everybody that's been scheduled at so far, if everybody goes through, we will have an 80% FIT positive to colonoscopy rate this fiscal year, which will be our highest FIT positive colonoscopy rate that we've had. Most years we run about a 70% FIT positive to colonoscopy. Cologuard is new for us for this past year. We are running about a 13%. I think it's 13. It might be. Yeah, I think it's 13% Cologuard positive rate, which aligns with their rate. And right now we're having a little bit harder getting those patients to have their colonoscopy. Not that we don't have the availability, it's the patient that we're working through their barriers or their fears of the colonoscopy. So right now we're sitting at a 40% Cologuard positive to colonoscopy, but we're working on trying to identify what are the reasons why those patients are not going on to get their colonoscopy, because we do remove barriers for our patients. That any patient that's doing colonoscopy through our program, we have Uber Health contract, we have guest cards. We have GIs that speak Spanish that partner with our program. We also have our bilingual navigators that will attend the colonoscopy appointment if they do not have a non-family member that can translate for them. So the only barrier that we cannot remove in regards to a colonoscopy is having a caregiver go with them. Just because of legalities, we cannot have our staff be that person. So sometimes we do lose patients due to not having a caregiver.
The next question is, could we refer a community member from Craig, Colorado, for instance?
Not to our program, because our funding is from the state legislature from South Carolina, and based upon our funding guidelines set forth by the state is that they have to live and reside in the state of South Carolina. And Jan might be able to answer that question in regards to being referred to your program.
Yeah, absolutely. And I know Sam, she's our patient navigator, responded in the chat. That's what we're hoping for. I mean, if you are in Colorado, that's, you know, they're all eligible. So if you have patients that you want to get referred to our program, we'd love to work with you on that.
And for you, Jan, could you please email me the referral form? And that was, she's got her email in the chat, and I can also copy that and send it to you.
Yeah, I can do that. And then I'm hoping the slides are available to everyone as well. But I'd also like to maybe put some contact information for our program leads that I talked about early on.
That would be great. Another question just come in is, how are the cuts to CDC and CDC funding going to affect the funding of these programs, and the cuts to Medicaid and ACA from the big beautiful bill may increase the need?
I can answer from my perspective from South Carolina, and then Jan may have information more specifically to Colorado. So because we are state funded, our funding is secure. It's not attached to Medicaid, and we are recurring line item in our state budget. So it would take a lot to get our money removed. And South Carolina did not expand Medicaid, so we may not have as big of an impact in regards to other states that did. And so we're just waiting to see in regards to that. CDC, like I mentioned, we were a recipient for the past 5 years. That funding ended on June 28th of this year. Back in February, we applied for the next 5-year funding. We have received, there is some communication coming out from CDC in regards to those that have applied for the next 5-year CRC-CP funding, that there is funding, and that they're just waiting for the final budget allocation to determine funding levels. So in regards to our screening program, will still be here no matter what comes out of the big, beautiful bill.
And we don't receive any CDC funding, so it wouldn't necessarily affect our program. When we refer for colonoscopy and or treatment as needed, we use mechanisms like charity care, hospital discounted care for the patients. So not to say there's probably going to be some impact. I think, Joel, you asked that question, but for ours, at least the CDC funding won't affect us.
Another question, in terms of community outreach activities, have you had to change strategies to reach community members given the current environment? And if so, what are you doing differently?
So if I could just defer to Daniel, if you're still on, and since you're leading this, if you're comfortable responding to some of the strategies that you put forward. Daniel, are you there?
Sorry, I was solving another problem over here. What's the question?
Just how have we had to sort of pivot given the current climate and trying to do outreach activities? I don't mean to put you on the spot, but I know
no, it's fine. No, I've been through this a few times. Like the first time there was a person got elected, that the first Trump election, and then when I was living in Texas, it happened as well. So we were going to see like a huge decline in undocumented participants. Anything that has to put down their address. So we haven't really, it hasn't really been long enough, or we haven't had, I would say, enough volume over the past few months in the program in general to really kind of measure that decline. But that's what I would anticipate, just because so many of our participants are Spanish speaking. So when you're going after that, like the person without a medical home and the person without insurance in one of the better states like Colorado, that ends up really meaning under and undocumented, in my experience.
Sam, I see you wanted to say something as well. Sam's our navigator.
Hey guys, sorry, I was off camera eating my lunch. Yeah, just to add to what Daniel said, I think something that is really great that our community outreach liaisons do, Tatiana, Cindy, and Carelli, is we establish relationships with clinics, and the clinics host events, as Jan was saying before. Before we had 365, which was a trusted resource for health fair events. So people are seeking this information. And so the clinics that people are getting this information from, it's their trusted providers, their trusted healthcare teams. So when they see that they're partnering with us, that is helpful in a climate like this, because people aren't going to answer phone calls from numbers they don't know. They're not going to answer questions. And thankfully, we're able to use texting as a resource, which I know the South Carolina team mentioned as well. And that's huge because as a navigator, if I'm trying to reach you for a positive and you don't answer my calls, I'm going to persist in other ways. Daniel had a great idea. We send a certified letter as part of that process. After 5 attempts, I'm going to send you a certified letter and say, hey, I've been trying to reach you. And as Jan said, we do it in the language, preferred language of that person. So those are some of the strategies that I think are helping us right now. And as Jan mentioned, last year was our first year doing this. So this is our second year and we're having repeat patients. So we've established trust with them. Hey, it's the cancer center, even though we're not, as Jan said, an FQHC or a clinic in ourselves or a cancer center. But they're like, oh, I know you guys. You guys are the university. You guys give me free stuff. I got free sunscreen. I got a free colorectal kit. Right on. We have other resources. So lots of ways that we're trying to help combat that mistrust that could happen.
Yeah. And just to add to what Samantha said, even though I'm not in Colorado, but because we do partner with clinics specifically for our referrals, we have had specific clinics call us and say, we have a patient who doesn't want his address, they don't want their address in the system. Can you communicate with the patient and mail everything to the clinic? And so we absolutely do that. So that way, one, they still that individual has trust in their medical clinic, which is great to see. So we just work everything through that patient's medical clinic in regards to getting them screened.
We thank you very, very much. For those who might want to look in the chat, Jan Lowery has put in their information on the kits in the program. And also remember to complete your evaluation. We greatly appreciate your participation and hope it's been helpful for you. We will follow up with any questions we didn't get to.
If you have time to stay on, we will go over some of the resources that are available in Colorado. And I think that's Ian and Ellie.
Thanks, Peggy. Thanks to folks who are able to stick around a little bit longer. So as you can see on the slide, we, the Colorectal Cancer Task Force of the Colorado Cancer Coalition, borrowed an idea from our colleagues in Missouri who have put together these colonoscopy resource guides for their entire state, which, as we are learning, is a very big lift. So we are giving it a shot in 2 areas, but essentially we tried to put together as much information as we could for those who have a positive stool test, are self-pay patients, and need to find a follow-up colonoscopy in their area. As folks know, colonoscopies, it's not just one payment necessarily to one health center. It often includes a facility fee and a provider fee, then anesthesiology. Anesthesia can be separate as well as pathology. So trying to pull together all the costs so that the patient has an idea of what the entire cost of the service will be. Right now, these are meant to be provider facing. So anyone on the care team, patient navigator, MA, nurse, whoever it may be that's interacting with the patient on barrier reduction to refer to these. So they're not necessarily meant to be patient facing. They don't look real pretty. But they do have as much information as we could find for each location in the Central Mountains and the Western Slope. And as it says in the slide, they are available in both English and Spanish.
All right, thanks, Ian. And thanks everyone for sticking around here. So I'll go through this pretty quickly. So I'm Allie Bain. I'm with the American Cancer Society, and I'm just going to share a few different kind of resource repositories that different organizations have put together that have a lot of great resources for folks, because I'm a big believer in don't recreate the wheel. So this is the resource repository from the National Colorectal Cancer Roundtable. And so you can see on the left side the different ways that you can filter to find exactly what you're looking for, from educational opportunities to different resources and materials for patients, for providers, for different settings, and for different target audiences. You might have to help me. Oh, there we go. This is one example specifically that covers these priority populations that we just talked about. So these are messaging guidebooks that have recommended messaging to help get folks screened. And there is a rural specific a section for folks living in rural areas. And then you can see on the right side of the screen that there is a specific Hispanic and Latino guide for messaging as well. This is an upcoming resource or upcoming webinar from the National Colorectal Cancer Roundtable focused specifically on rural best practices, and they're releasing a new guidebook. So for folks that are living or working in rural areas, this is we're looking forward to seeing this and assume it'll be a great resource. Oops. The Colorado Cancer Screening Program here in Colorado has put together a massive repository of different resources, including resources you can use for Colorectal Cancer Awareness Month in March. So I would encourage folks to take a look at that. And then also some social media toolkits. So this is one example that was put together by George Washington Cancer Center as part of the Technical Assistance Program for Comp Cancer programs and cancer coalitions in the country. And then this is a social media toolkit that was put together by the Colorectal Cancer Alliance that has some really fun different visuals. So we know if people are always looking for social media tools. So this is, a great example of you can use some of these resources. All right, and then just to wrap us up, I've shared in the chat a couple of times, we encourage you to fill out our evaluation, let us know what future learning opportunities you're looking forward to. And then I also shared in the chat, if you're interested in joining the Colorectal Cancer Task Force of the Colorado Cancer Coalition, which is the group that helped to put this webinar together, feel free to join our group. There's no pressure. We meet once a month, share information, best practices, resources, and put together great educational opportunities like this. So with that, thank you everybody for joining us today. And I hope that you